Hello, this is Qasim Barada. I'm giving you this VOP on liver cirrhosis and its complications. My colleague, Dr. Fadi Francis, participated in the preparation of this presentation. The objectives of this presentation are first to know the definition of cirrhosis. The second one is to develop the ability to make the diagnosis of cirrhosis on clinical grounds, meaning based on the history, the physical exam, laboratory tests, and imaging without a liver biopsy. We also would like you to understand the pathogenesis of cirrhosis development. How does it happen? And all importantly, we need to recognize the presence of complications of cirrhosis. We will be focusing on ascites, esophageal varices, hepatic encephalopathy, and hepatorenal syndrome. We need to recognize the presence of those complications. We need to know what the best modalities we have are to prevent them and to treat them.
Cirrhosis is the end stage of any chronic liver disease, regardless of the type of liver injury. It is histologically characterized by regenerative nodules surrounded by fibrous tissue. This fibrosis and distortion of the vascular bed within the liver will lead to portal hypertension. And clinically, we have two types of cirrhosis. One is compensated and one is decompensated, and this will be explained later on during this session. On the left side, you will see the normal morphology of a liver. On the right side, you see a cirrhotic liver with nodules and fibrous tissue. On this slide, you will see the normal histology of the liver on the left side, and on the right side, you see nodules surrounded also by fibrous tissue. So what is the pathogenesis of cirrhosis? To understand the pathophysiology of cirrhosis, we have to recall the basic liver structure. The slide depicts the basic liver structure where you have in the middle a sinusoid that is a blood vessel that drains blood from the portal areas to the central vein. This vessel is lined by endothelial cells that are normally fenestrated, meaning there's a little space between them. Between the sinusoids and the hepatocytes, represented here in blue, is the space of this. Within the space of this, there are cells called hepatic stellate cells that in normal liver just contain vitamin A. Any injury to the liver, for example, excess alcohol intake or any chronic virus like hepatitis B or C, will lead to activation of the stellate cells. These stellate cells will start depositing collagen in the space of this. This will constrict the sinusoids and will lead to their defenestration. So the pressure within these vessels, the sinusoids, will increase, and that will lead to portal hypertension.
So what are some common causes of cirrhosis, common etiologies of cirrhosis? The three most common ones are alcohol misuse. The second one would be MASH, metabolic dysfunction associated steatohepatitis, previously called non-alcoholic steatohepatitis. This entity is seen most commonly in patients who are obese, who are diabetic, who have the metabolic syndrome, and also post-viral, i.e. patients who have chronic hepatitis B or chronic hepatitis C. There are some other etiologies such as chronic biliary obstruction or intrahepatic cholestasis caused by, for example, primary biliary cholangitis. Autoimmune conditions such as autoimmune hepatitis can lead to liver cirrhosis. Patients with heart failure can develop what we call cardiac cirrhosis. There are some metabolic causes such as Wilson's disease or hemochromatosis. We discussed those. Drugs can cause liver cirrhosis, for example, methotrexate. And when we don't find any cause of liver cirrhosis, we call it cryptogenic.
So in whom should we suspect cirrhosis? In fact, any patient with chronic liver disease who has chronic abnormal AST and ALT and or alkaline phosphatase, or if on physical exam you have findings of chronic liver disease, meaning muscle wasting, vascular spiders, pulmonary erythema, a palpable left lobe of the liver, a small liver span on percussion, if you find a splenomegaly or collateral circulation, mainly caput medusa that we will see later on, or any signs of hepatic decompensation, mainly the patient is yellow or has jaundice, ascites, which is accumulation of fluid in the abdominal cavity, or if they have flapping tremor or asterixis. This is a picture of a caput medusa where you have varices or dilated veins that radiate from the umbilicus, and that's a sign of portal hypertension that you see in cirrhosis. So what are the laboratory findings in cirrhosis? In cirrhosis, there is decrease in the synthetic liver function. So not enough albumin will be made and the albumin in the blood will be low. Not enough clotting factor will be made. That will lead subsequently to prolongation of the prothrombin time and the INR. Also, bilirubin can be increased. Because cirrhosis causes portal hypertension, the spleen will be enlarged. The splenomegaly will lead to sequestration of the platelets within the spleen. Subsequently, the platelet count will drop. Imaging studies in cirrhosis, CAT scan, ultrasound, or MRI can show you a nodular liver, can show you signs of portal hypertension like splenomegaly or venous collaterals. This is a CAT scan showing you cirrhosis. On the left side, we see the liver with an irregular surface. On the right side, in the center of the picture, you have a lot of collaterals and splenomegaly, which are signs of portal hypertension that is associated with cirrhosis. So what is the natural history of chronic liver disease? So you have someone who has chronic liver disease manifesting by abnormal liver enzymes, and many of those patients don't even know they have chronic liver disease. With time, the fibrosis worsens and they end up having compensated cirrhosis. It comes a day where they decompensate, meaning they have either a variceal hemorrhage, or they have ascites, encephalopathy, or they turn yellow and have jaundice, and that's what we call decompensated cirrhosis. Once decompensated, there's a quick progression to death. This slide shows you how decompensation shortens survival. In all patients with cirrhosis, the median survival is around 9 years. In those who are decompensated, meaning they have hepatic encephalopathy, variceal bleeding, or ascites, the mean survival is 1.6 years. So whenever a patient is decompensated, we refer them for liver transplantation. The Child-Turcotte-Pugh score is a score that can tell you how severe the cirrhosis is or will grade how bad the cirrhosis is. It assesses 5 parameters being encephalopathy, ascites, bilirubin, albumin, and prothrombin or INR. And depending on the severity of each one of these 5 parameters, you can have a number. If the number is between 5 and 6, we call that child A cirrhosis. Between 7 and 9, it's child B cirrhosis. Between 10 and 15, it's child C cirrhosis. The higher the number, the more severe the liver disease is. So most complications of cirrhosis will result from portal hypertension. To further elaborate on portal hypertension, we need to talk a little bit about the mechanisms that lead to portal hypertension. Pressure within a vessel results from interaction of resistance and flow. So pressure equals resistance multiplied by flow. Portal hypertension can result from increase in resistance to portal flow and or increase in portal venous inflow. In cirrhosis, the increase in the hepatic resistance is the initial mechanism leading to portal hypertension. As we explained before, the hepatic stellate cell will secrete collagen that will compress the sinusoids, leading to increased resistance within the sinusoid. This will subsequently lead to portal hypertension. So what causes portal hypertension? Cirrhosis is not the only etiology of portal hypertension. It is the most common one, but it's not the only one. As we mentioned before, the side of increased resistance in cirrhosis is sinusoidal. The pressure is at the level of the sinusoids. Other causes of portal hypertension are classified according to the site of increased resistance. This table will give you just examples of other causes of portal hypertension not related to cirrhosis. You can have a prehepatic portal hypertension as you see in portal or splenic vein thrombosis. You can have an intrahepatic pre-sinusoidal portal hypertension as you see in the infection schistosomiasis. The third is sinusoidal portal hypertension like you see in cirrhosis. Again, this is the most common reason of portal hypertension. You can also have post-sinusoidal intrahepatic portal hypertension like you see in sinusoidal obstruction syndrome. And then you have the post-hepatic portal hypertension like you see in Budd-Chiari syndrome. Don't worry about these diseases. These will be given and explained in different lectures. So what are the complications of portal hypertension? We have varices, ascites, and when infected, we have spontaneous bacterial peritonitis or SBP, hepatic encephalopathy, hepatorenal syndrome, portopulmonary hypertension, and hepatopulmonary syndrome. These are the most common complications. We're going to start with varices. In portal hypertension, blood flows away from the portal venous system through portosystemic collaterals. This occurs because collateral resistance is lower than that of the intrahepatic vessels. So these collaterals can form in the stomach or the esophagus, and we end up having esophageal or gastric varices, can form in the rectum. We can have hemorrhoids or rectal varices, can form around the umbilicus, and that's called caput medusa. And they are rarely retroperitoneal. Here you see the endoscopic appearance of esophageal varices. On the left side, this is a normal esophagus with no varices. In the middle picture, you see small varices where you have these cords of dilated veins, the bluish ones. And on the right side, they are more tortuous, they are larger. These are large varices. The pressure inside them is high, so they can rupture and bleed. The risk factor for variceal hemorrhage include the size of the varix. The larger one bleed more. Endoscopically, if you have red whale signs or cherry red signs. If you have child C cirrhosis as compared to child A or child B, the worse the liver disease is, it means the worse the child class is, the more risk of bleeding. Also, if you have a hepatic venous pressure gradient of more than 12 millimeters of mercury, this is a gradient that gives you the difference of pressure between the portal circulation and the systemic venous circulation. If it's more than 12, then there's a higher risk of bleeding. The slide depicts variceal hemorrhage. On the left side, where you see a varix that is actively bleeding. On the right side, you see a varix that is large with red whale signs. So what is the treatment of esophageal varices? If they are not bleeding, we do give beta blocker therapy like propranolol, nadolol, carvedilol that will decrease the pressure within the varices, mainly decreases portal hypertension. But if the patient cannot tolerate these medications, especially if the varices are large, we can perform variceal ligation, which is placement of a rubber band around the varix. If the varices are bleeding, we first have to resuscitate the patient. We can give blood transfusion, but we should not over-transfuse, because if we over-transfuse, the pressure within the portal system will continue to rise and will lead to more bleeding. We give antibiotics to prevent an infection, and then we give medications that will decrease portal hypertension, like terlipressin, somatostatin, and octreotide analogs. In addition, we do perform endoscopic therapy, which is variceal band ligation or sclerotherapy, but usually the most commonly used technique is variceal ligation. And if all fails, we then proceed to a shunt placement, which is tips that we will explain about later on. Endoscopic variceal band ligation or bending is the placement of a rubber band around the bleeding varix through the scope. It controls the bleeding in 90% of the time. The rebleeding rate is around 30%. There is another method to control bleeding endoscopically called the sclerotherapy. In sclerotherapy, we inject a sclerosing agent into the varix. Compared with sclerotherapy, variceal band ligation has less rebleeding, has lower mortality, fewer complications, and fewer treatment sessions. So it is the number one endoscopic method to control variceal hemorrhage. Now we will be talking about ascites, which is another complication of portal hypertension. So what is ascites? Ascites is the accumulation of fluid in the peritoneal space. The peritoneal cavity is a potential space between abdominal organs containing less than 25 cc of peritoneal fluid, acting as a lubricant. Whenever this fluid is more than 25 cc's, we call it ascites. Cirrhosis is the most common cause of ascites. In fact, in 85% of the time, cirrhosis is the reason for the ascites. Other etiologies of ascites include malignancy, heart failure, renal disease, pancreatic disease, and others.
So what is the pathogenesis of ascites formation? You have basically sinusoidal outflow obstruction. What does that mean? We have or hepatic venous outflow obstruction. What does that mean? You have fibrosis developing within the sinusoids and in the space of disci. You have defenestration of the endothelial cells, leading to increased resistance to flow within the liver bed. So that leads to oozing of fluid from the surface of the liver, the weeping liver or al-kabid al-baki. That's one mechanism. The second one is that the pressure is transmitted to the splanchnic capillaries, leading to oozing of fluid or transudation of fluid into the peritoneal cavity. The third one is the hypoproteinemia that happens in patients with liver cirrhosis, leading to reduced oncotic pressure and movement of fluid from the intravascular to the interstitial space. And the fourth one, which is very important, is that there is usually in cirrhosis massive splanchnic arterial vasodilatation. And that creates a situation in which the kidneys perceive that the intravascular volume, the effective intravascular volume, is low. The sensors of the body perceive that the intravascular volume is low. It's actually high, but they perceive it as low because of the massive splanchnic vasodilatation. That leads to activation of all the vasoconstrictors in the body. Epinephrine, endothelin, angiotensin, renin, leading to massive sodium and water retention at the level of the kidney. All of those factors contribute to ascites formation.
In patients with ascites, we need to analyze the ascitic fluid. How we do that? We perform what we call a paracentesis. A paracentesis is when you put a needle in the abdominal cavity to remove some of the ascitic fluid. Indication for paracentesis include new onset ascites, any symptoms or signs of an infection of the ascitic fluid, if you have renal dysfunction, unexplained hepatic encephalopathy, or at the time of admission to the hospital. The ascitic fluid should be analyzed with routine tests always done and some optional tests. The routine ones include cell count, RBCs and WBCs with differential, culture, albumin, and protein. The optional one, depending on what you're suspecting, you can send for cytology if you suspect malignancy, or amylase if you suspect pancreatic disease, etc. Whenever you send the acidic fluid for analysis, you should also check a serum albumin so you can calculate the serum minus ascites albumin gradient, or SAG, SAAG. If the SAG is more than 1.1 gram per deciliter, this is consistent with cirrhosis or portal hypertension, and also can be seen in cardiac disease. If the SAG is below 1.1, that can be seen in many different diseases, including renal disease, cancer, tuberculosis, or others. So how do we treat ascites? The cornerstone of treatment is sodium restriction. As we know from the pathophysiology of ascites, sodium retention is a major contributor. So we tell our patient to restrict their sodium or salt intake. This is done in combination with giving diuretic therapy. Usually we give a combination of a potassium-sparing diuretic like spironolactone and a loop diuretic like furosemide. The combination of salt restriction and diuretic use is effective in 90% of patients. For those who don't respond to this combination, we perform large volume paracentesis where we drain the fluid by placing a needle in the abdominal cavity. We can also perform TIPS, the same way TIPS works for variceal hemorrhage, it can work for ascites. And the best treatment is to give the patient a new liver by performing liver transplantation. Now we will discuss spontaneous bacterial peritonitis, or SBP. We know that bacterial infections are common in hospitalized cirrhotic patients. As you see on this slide, in non-cirrhotics, hospitalized patient infection is around 8%, but in cirrhotics is around 34%. SBP is the most common infection in cirrhotic patient as compared to UTI, pneumonia, or a procedure-related bacteremia. So what's the mechanism of SBP? We know in SBP there's increase in bacterial translocation between the intestinal lumen and the peritoneal cavity. Because of cirrhosis, there's intestinal bacterial overgrowth, there's increase in intestinal permeability, as well as impaired immunity. All these factors combined will lead to the increase in translocation of bacteria from the intestinal lumen to the peritoneal cavity, subsequently leading to infection and SBP. So what are the clinical characteristics of SBP, or spontaneous bacterial peritonitis? Patient can present with fever, jaundice, abdominal pain, confusion with hepatic encephalopathy. On physical exam, they have abdominal tenderness. They can be hypotensive, but up to a third of them will have no symptoms. How do we diagnose SBP? We have to perform a diagnostic paracentesis, and the fluid should be sent for analysis. If the polymorphonuclear count is more than 250 cells per cubic millimeter, then you make the diagnosis of SBP, or if the culture is positive. The treatment is to give intravenous antibiotics, preferably cefotaxime, in addition to intravenous albumin. Now we're going to discuss another complication of cirrhosis, which is hepatorenal syndrome. Hepatorenal syndrome is progressive renal failure associated with advanced cirrhosis and ascites in the absence of any other cause of renal failure and without the presence of any previous renal disease. This syndrome occurs in the setting, again, of advanced liver disease, mainly cirrhosis, usually occurs after hospitalization without any precipitating factor. Its clinical features include ascites, hypertension, oliguria, and jaundice, and typically it will lead to death within weeks. Laboratory findings, you do have hyponatremia, elevation of creatinine and BUN, and most importantly, the urine sodium is below 10 milliequivalent per liter and most of the time below 5 milliequivalent per liter.
To understand hepatorenal syndrome, we need to recall the definition of acute kidney injury. AKI or acute kidney injury is diagnosed by an increase in serum creatinine 0.3 milligram or more within 48 hours, or more than or equal to 50% increase in serum creatinine that is known or presumed to have occurred within the preceding 7 days from presentation. Hepatorenal syndrome is a type of acute kidney injury known as HRS-AKI, previously known as HRS type 1, unique to patients who have cirrhosis that occurs in the absence of hypovolemia or significant abnormalities in kidney histology. It is diagnosed in those patients with cirrhosis who do not respond after 2 consecutive days of diuretic withdrawal and plasma volume expansion, do not have shock, have no current or recent use of nephrotoxic drugs, and there is no sign of structural kidney injury, meaning their kidneys look normal on ultrasound and they have no evidence of proteinuria or hematuria.
So how do we manage patients with hepatorenal syndrome? The first thing to do is to administer albumin, which will increase the intravascular volume and improve the oncotic pressure, plus a selective splanchnic vasoconstrictor. Remember that there is massive splanchnic arterial vasodilatation. What you want to do is oppose that by administering a selective vasoconstrictor such as terlipressin, which is more selective to the splanchnic circulation than other vasoconstrictors. This is an expensive medication. It's not available in Lebanon. If you don't have it, you can try norepinephrine, which is also another vasoconstrictor. It is not a specific one, plus albumin, of course. And you can do hemodialysis as a bridge to liver transplantation, which is the only definitive treatment. What is good about the management of hepatorenal syndrome is that nowadays we can reverse it in about 50% of patients. What is bad is that it is a sign of very advanced liver disease and imminent death. Patients will die shortly after developing hepatorenal syndrome if you don't reverse it.
Another complication of cirrhosis is hepatic encephalopathy. Hepatic encephalopathy is the encephalopathy of cirrhosis. It's a constellation of neuropsychiatric manifestations, results from spontaneous or therapeutic portosystemic shunting in addition to chronic liver disease, is due to failure to metabolize neurotoxic substances, mainly ammonia. It is associated with alteration in astrocytes morphology and function in the brain. These astrocytes normally metabolize ammonia. In cirrhosis, these astrocytes are no longer able to metabolize ammonia, and this will lead to hepatic encephalopathy. So what is the pathogenesis of hepatic encephalopathy? So here you see the colon down below in the middle of the screen. Inside the colon, if you have a big protein load, eating hamburgers, or for example someone with GI bleed, that constitutes a big protein load. Under bacterial action, there's a production of ammonia. Ammonia will be then absorbed into the portal system. It is not metabolized in the cirrhotic liver, and it will be shunted directly into the brain, where it acts on the GABA receptors and the benzodiazepine receptors, leading to hepatic encephalopathy. This again shows the 4 stages, being confusion, drowsiness, somnolence, and coma. This slide depicts asterixis or flapping tremor. That's the tremor you see in hepatic encephalopathy. You ask the patient to extend their wrists as they are stopping traffic. Then you start seeing an involuntary back and forth movement of the wrist. So what can precipitate hepatic encephalopathy? Excess protein intake, gastrointestinal bleeding, the use of hypnotics or sedatives, any electrolyte abnormality. Some of them can be induced by diuretics, any infection, or portosystemic shunting like TIPS placement. So how should hepatic encephalopathy be treated? we first should treat any underlying precipitating factor. So if your patient is having gastrointestinal bleeding, you should first control the bleeding. If the patient has an infection, this infection should be treated. We can also decrease ammonia production and increase its elimination in the gut by using medication like lactulose and rifaximin. This slide depicts the actions of lactulose. Lactulose is a disaccharide. It is metabolized in the colon to lactic acid. Lactic acid will decrease the colonic pH. The decrease in colonic pH will lead to a decrease in the urease producing bacteria that give ammonia. Also, the decrease in pH will give an extra proton. This extra proton will transform ammonia, which is NH3, to NH4+, which is ammonium. Ammonium is excreted in the stools and is not absorbed into the bloodstream. Also, lactulose acts as a cathartic on the colon.